Thank you very much, everybody. We had a slight hiccup on technicalities. We solved that. Firstly, welcome, everybody. This is day 2. As you saw on day 1, as I earlier said, we had talked about the past and present, the ghosts of the past and present, as I said, how we looked at the diseases of the past and how we managed through Africa. And then we looked at COVID and how we overcome that, and we're trying to overcome that. Now, this is about the future. This is to prevent the ghost of the future. As you know, one of the biggest treaties that is circulating the rounds to be negotiated with 4 African countries pushing heavily on it is this pandemic preparedness treaty. Now, what this treaty is trying to bring on force is all the lessons we have learned during what has happened during COVID. But there's an older pandemic that's building up quietly in the background, and that is the antimicrobial resistance. We know that we are running out of antibiotics that can deal with this. Every year we do get notification of this or that antibiotic is failing on this and that condition. And these superbugs are evolving. It's a constant war in the front. It's a war that's taking place inside the surgery wards. It's a war taking place outside in the population. And today we are assembling a great panel for Africa to prepare us for that, to prevent the ghost of the future coming and affecting our progress. We've got Dr. Walter Fuller from the WHO action plan and also on the AMR stewardship issues. We then got we've got Dr. Michael Anderson from London School of Economics and Political Study, who's done a great study from Cape to Cairo, I call it. Two aspects of from South Africa and in Egypt, 2 case studies, what is happening in that. Then Bisi Bright, our board member from Nigeria, is with us. She will talk about what the pharmacists are doing and how pharmacists frontline, I suppose, in a way, to check this progress of the AMR resistance. It's through their own prescription methodologies and advice they give that they can prevent this and improve stewardship. Then we've got Dr. Chrispin Kambili, who's from the Johnson & Johnson. He is a lead global public medical affairs, global public health. And Dr. Kambili brings in this great insight of how, in a particular aspect of TB and in the TB's function, how this is really plays out, you know, how AMR is really playing out in this old programs. We haven't got rid of this disease for over 60 years and we still time. Then we have got Dr. Greg Frank, who's from the Global Public Policy Director at MSD. Dr. Frank has great credentials and has an approach in One Health. This is looking at collectively health of not only individuals, but within the ecosystem itself, and bringing how this brings together into One Health approach to AMR. And then Dr. Nicholas Adomakoh, who is the Medical Affairs Director at Anti-infectives at Novartis and Sandoz. And he will then bring in an alternative insight, again, from what is going on from the perspective of the industry partners. As you know, majority of the industry partners have joined up the AMR Action Fund, trying to look for new solutions. And then Dr. Murphin Mpundu, who is the director of REACT Africa. Dr. Murphin will look at several aspects and look at real world, how that is done and how AMR program and its implementation and other aspects are looked at. But last but not least, I must introduce our moderator today. And our moderator today is Danjuma, who is the president-elect of the World Hepatitis Alliance. And as you know, they are the most worried group in Africa at the moment. and AMR is yet another burden that may fall on to the patients, and they would like to get this. Over to you, Dan. Please lead us to this marvelous session and the elite of Africa, and let's see how we can prevent this ghost of the future. Thank you very much, Dan. Over to you.
Thank you, Kawaldeep, and thank you so much, IAPO, for giving me this privilege to moderate this session with this wonderful array of speakers. Great panel that we have here today. Kawaldeep has rightly said it, that the COVID-19 pandemic shook the whole world, and economies were shaking. Countries have still not even recovered. We're still really on the throes of the COVID-19 pandemic. But one other pandemic, which I will say the world is sitting on the gunpowder, on the precipice, is the antimicrobial resistance. And this is what affects everybody. Or in fact, from the farmer in Lesotho, to the patient in Jalingo, to the clinician in Lagos, or the clinician in Rwanda, antimicrobial resistance affects almost everybody. And what we're now asking is Africa prepared? So that's why this session is about antimicrobial resistance in Africa, the next pandemic. Are we prepared as a continent to address this pandemic? And we have, as Kawaldeep has introduced, this wonderful array of speakers to guide us in the conversation this morning. So I will start with by calling on Dr. Walter Fuller, who is on WHO Afro, to start his presentation, and each speaker have 10 minutes for their presentation. So Dr. Walter Fuller, the floor is yours to present your paper on the preparedness of Africa as a region on the antimicrobial resistance. Dr. Walter Fuller, over to you.
Thank you. Antimicrobial resistance, the silent pandemic, as you've just mentioned, today constitutes a global public health security threat that will adversely affect all regions and countries, with an impact that is estimated to be disproportionately more severe in low- and middle-income countries. We are gathered here today as a testament of our resolve to curtail this silent pandemic. This resolve is born out of the urgency and the threat that AMR poses to modern medicine, public health leadership, our food supply chain, to our environment. AMR, more significantly, as it applies to our region, is the quintessential threat to its overall development. Current estimates show that at least 700,000 people die each year from drug-resistant infections. 230,000 of those are people who die from multi-drug-resistant TB. If nothing is done, as current estimates put it, 10 million deaths will occur each year by 2050. And more alarming, 4.1 million of those 10 million deaths will be from the African region. In addition, 24 million people could be forced into extreme poverty, and most of them will be from low middle-income countries. The impact of AMR is therefore cross-cutting, with far-reaching implications to critical priorities across human, animal health, agriculture, environment, and economic sectors. AMR is therefore not just a health, agriculture, or environment issue. It is an encompassing societal issue that affects each and every one of us. And to be fair, we all have played a part in causing it. And we all therefore must actively work together as a society to consistently address it. In this regard, there is no room for complacency, as AMR threatens to undo the gains in the area of modern medicine, global health security, health systems strengthening, the attainment of universal health coverage, all of which are critical to ensuring overall health and well-being for our people. The lack of effective and assured supply of these precious medicines will inevitably put our public health emergency preparedness and response efforts at risk. Across the board, AMR threatens the achievement of sustainable development goals and would significantly roll back gains made in addressing poverty. As a direct consequence, we could see additional cost in health expenditure increase from $0.3 trillion to $1.2 trillion by 2050. This will lead to a significant disruption in the current baseline trends, which were on target to eliminate poverty by 2030. In the WHO African region, we are working with member states and stakeholders to develop, implement, and monitor AMR national action plans in line with the objectives of the Global Action Plan and in the context of our transformation agenda and the WHO 13th General Program of Work. This General Program of Work outlines WHO's public health leadership with a focus on driving impact at country level based on 3 major targets, which are: 1, ensuring that 1 billion more people with essential health services are covered, 1 billion more people are made safer, and 1 billion more lives are improved. It is important to note that these priorities will not be fully achieved if we do not address AMR within the context of these priorities or address these priorities within the context of AMR. Guided by WHO's General Program of Work and its transformation agenda, WHO Afro is leveraging the One Health multisectoral approach to support member states to strengthen in-country capacity to deliver in key areas such as surveillance, laboratory awareness, infection prevention and control, antimicrobial stewardship to optimize use, which will contribute to the triple billion goals and drive sustained long-term impact at country level. On this note, I want to note a number of activities that we've been carrying out. We've been supporting One Health and multi-sectoral coordination activities in partnership with the Tripartite, that is the Food Agricultural Organization of the United Nations, the World Organization for Animal Health, and other stakeholders such as Africa CDC, the African Union Inter-African Bureau for Animal Resources, and the UN Environment Programme. Together with these partners, we organized in November 2020 the African continent's second joint campaign and first virtual campaign for World Antimicrobial Awareness Week, which was a great success with over 1,200 participants across different sectors, including civil society organizations. In addition, the execution of the WHO Afro-Africa CDC Joint Work Plan across a wide range of activities is also a testament to this collaboration. We are also supporting countries to counter AMR, as I mentioned before, in the context of the Global Action Plan, the international health regulations, and the regional strategy for health security and emergencies. So far, in line with the One Health approach, the WHO African region has supported 38 countries to develop their national action plans. 27 of those national action plans are approved by national authorities. And we will continue to advocate for the development and updating of these plans in collaboration with the FAO, OIE, and other important stakeholders. Antimicrobial resistance is made worse by the misuse and abuse of antibiotics. For those in our region, you can see them in every street corners, in most markets. The COVID pandemic has exacerbated this problem. Recent studies suggest that 72% of hospitalized COVID-19 patients received antimicrobials, but only 8% had infections that could be treated with these medicines. In line with strategies to optimize use of antibiotics, we are supporting member states to update their essential medicines list to include aware categorization of antibiotics, which enhances stewardship interventions to curb the misuse and abuse of antibiotics. In the coming days, we'll also be launching the WHO policy guidance on integrated antimicrobial stewardship activities in human health in our region. This, together with the Antimicrobial Stewardship Toolkit previously launched, is aimed at supporting our member states' established stewardship programs and strategies at national and health facility level to optimize the use of antimicrobials. We are also currently leveraging strong IPC programs in member states to support the implementation of hospital-based stewardship programs. This activity could be further enhanced in the context of ongoing work on IPC and WASH for COVID control. In the area of surveillance and data availability, so far 30 countries are enrolled in the Global Antimicrobial Surveillance Systems, known as GLASS. GLASS is a platform that promotes and supports the standardized approach to the collection, analysis, and sharing of AMR data at a global level by encouraging and facilitating the establishment of national AMR surveillance systems that are capable of monitoring AMR trends, producing reliable and comparable data. We will continue to encourage and facilitate the enrollment of all member states to GLASS and promote sharing of data for decision-making. In this same vein, 10 African countries have established national antimicrobial consumption surveillance systems. 15 countries have carried out point prevalence surveys on antimicrobial use in hospitals. Data from this work will inform policy stewardship interventions at national and health facility level. So far, 49 laboratories from 28 countries are participating in the WHO External Quality Assurance for Antimicrobial Susceptibility testing. In the area of awareness, considering that awareness and education is vital to ensuring that health professionals, policymakers, patients, society at large are equipped to be part and parcel of the solution in addressing AMR, WHO has developed a website with comprehensive context-based tools and materials to help member states, institutions, professionals, policymakers, and laypersons understand what the problem is and how they can be part of the solution. As part of our AMR campaign for the period of May to June 2021, after the launch of the website, our digital campaigns have been viewed over 129 million times and received over 46.1 million individual views. And the AMR campaign website has had over 35,000 visitors. The World Antimicrobial Awareness Week, apart from being an opportunity to raise awareness, also serves to build, reinforce, leverage a truly united front and one health multi-sectoral approach for addressing antimicrobial resistance at the regional and member state level. To change behavior and attitudes towards curbing AMR, a pilot initiative has been launched in Nigeria to train youths from 10 secondary schools in Lagos who will become AMR ambassadors in their respective communities. To date, there are over 300 youth ambassadors. We are in the process of scaling to additional schools in Lagos State and across Osun State in Nigeria. The work before us is monumental, but certainly surmountable if we stand united in addressing this problem. This means moving from mere rhetoric to action. This also means effectively leveraging across areas of common interest and ensuring effective One Health multi-sectoral coordination at all levels to drive impact on the ground. The WHO African region is committed and welcomes partnerships to help countries build resilient, equitable, patient-centered health systems that will keep the world safe, serve the vulnerable, promote health. Together, let us stand united by doing our best to preserve antimicrobials. In closing, let me, on behalf of the AMR team in the WHO Regional Office for Africa, thank the African Patient Congress, International Alliance of Patient Organizations, and the organizers for inviting us to this very important discussion. Such endeavors help keep AMR agenda alive and foster the regional collaboration that is so important to meet the current and future challenges. Thank you all.
Thank you, Dr. Walter Fuller from WHO Afro for this wonderful presentation. There is one quote I picked from what you said. You said, we all have played a role in AMR. Indeed, it is true. From the patient who pressures the doctor to prescribe him antibiotics, to the pharmacist who dispenses without prescription, to the farmer who uses the herbicides and all those chemicals, almost everybody is guilty of this. And that is why this session is looking at what the role, what can the patient, the community, the policy, the clinicians do in addressing AMR. We still have a lot of questions for you, Dr. Fuller, but we'll move on to the next presenter, Mrs. Bisi Bright, a board member in IAPO, to tell us her perspective and presentation from the perspective of the community pharmacists and what role have they played or are they playing in containing antimicrobial resistance. So, Mrs. Bisi Bright, the floor is yours. Thank you.
Good morning, good afternoon, good evening, everyone, depending on what part of the world you're in. It's a privilege to be here today to talk about the African community pharmacists and antimicrobial resistance. If you look at what's happening here in Africa, well, this picture just depicts the pharmacy, or the typical thing you see where a patient goes into the pharmacy, presents a prescription, but most times, if you look very well, this is actually just a piece of paper. So it's probably some type of self-medication that person is trying to do. Yesterday, we had the president of the Global Self-Care Federation who talked about self-medication and responsible self-medication. So this, we are saying, antimicrobial resistance, like our moderator said, is largely caused by a lot of self-medication. And of course, this self-medication is sometimes even caused by patients who pressure the practitioners, or when people go to the pharmacy and they want to get an antibiotic without a prescription. So let's look at other causes of antimicrobial resistance. You could have drug abuse, which is the commonest. People just want to pop pills and they feel this antibiotic is good. There's a lot of peer referral. You know, this person says, my neighbor says this is good for him, it works for him, and it should be good for me. And then polypharmacy, when people take a lot of medication together without even knowing what they're meant to do, or they know what it's meant to do, but they feel that there'll be synergy. The more they take, the more the cure they get. Then the open supply chain, which is very particularly common in Africa, especially in some countries, I'm not going to mention names, in Africa where you don't really have a highly regulated supply chain. And then we also have fake adulterated and spurious drugs. Those can lead to antimicrobial resistance, because if an antibiotic is supposed to contain a certain amount of an active ingredient and in short supply, it's a spurious drug, it can lead to resistance. Then we also have there's something we call antibiotic antagonism. I don't hear that being talked about very often, but it is one of the major causes of antimicrobial resistance, where a prescriber prescribes an antibiotic that is bacteriostatic along with a bactericidal antibiotic. Then you now have antagonism, and in that case, the patient got a proper prescription and it was a proper qualified prescriber that prescribed. But because of the pharmacology of the prescription, there is antagonism, and so there is treatment failure. So that is also one of the causes of antimicrobial resistance. And then low health literacy, and of course the health-seeking behavior. A lot of people have a very poor attitude towards health-seeking behavior. They believe they are sick when they're not sick, and they just start popping pills. And because there is an open drug supply chain, they take the antibiotics at will without any hindrances. Now, I decided that for this purpose, it would be good to take in to mention a few country experiences from around Africa. So I got one or two community pharmacists in Nigeria, Egypt, Zimbabwe, and Ghana to contribute to this. But because I knew that I had only 10 minutes, I just said, I'll quickly give an overview. Now, in Nigeria, we have what we call the Oga Chemist Sell Me Capsule Syndrome. Now, the antibiotic is typically called the capsule. There are many other drugs that come in capsules, but when the person goes to the, we have, apart from the pharmacies, we have the patent medicine stores, and then we have a lot of illegal medicine selling stores here. So people just, they call them chemists, these illegal stores, they call them chemists. And then someone says, Oga Chemist, sell me capsule. That means, it's in pidgin English, it just means, please give me an antibiotic. It's a syndrome, Oga Chemist Sell Me Capsule syndrome. And it's one of the syndromes that are responsible for gross antibiotic abuse. And I have a slide which I'm showing after this one, which is the presentation of the community pharmacists in Nigeria, where they're explaining the challenges they have and the pressure they face from society. Remember, the pharmacy is the first port of call for healthcare. It's near the community, it's very close to everybody. So there's a lot of abuse and people pressure the pharmacists. That doesn't mean they should yield, really. But they've given me a slide to present to highlight some of their challenges. Now, in Egypt, they are very well regulated. They don't have the challenges that the community pharmacists in Nigeria have. So that's a very good one. And then I was able to get some of the experience incentives from the Egyptian representative of the European Medicines Authority. You know, Egypt belongs to both Europe and Africa. Now in Zimbabwe, they are also very, very highly regulated. And in Ghana, they have the WHO Collaboration Center in Ghana, which works directly with the Uppsala Monitoring Center. So the regulation in Ghana is much better than in Nigeria, but generally there's a challenge in West Africa. I don't know whether to call it a geographical challenge because of the location. Because in West Africa, the infrastructure challenge tends to affect everything else. Now, this is the slide I got from the Nigerian community pharmacist. It was actually compiled by a very prominent community pharmacist called Mrs. Shade Lawal. And she talked about some of the efforts they're making in terms of enlightening people and enlightening the public, collaborating with other healthcare professionals. And they are also working with the Commonwealth Pharmacists Association on antimicrobial stewardship. However, most of their challenges are based on easy access by the public and then not enough collaborative practices, which the pharmacists themselves need to make more effort in that direction. And then poor regulation of antimicrobials, poverty, and of course the challenges in the health insurance system. So having talked about antimicrobial resistance in African countries generally, I'll just quickly go on to what it holds in stock as the next pandemic. COVID-19 has ravaged the world, and Africa has not even procured enough vaccines to bail out itself. Then the WHO director talked about infection prevention and control practices. He talked about IPC, and then he also talked about WASH. These practices are not really adhered to. We don't have IPC and WASH practices being adhered to. And as healthcare professionals, it's our duty to make sure that the public out there is aware. If they don't want to know, we need to keep reminding them. So you don't have enough masking, non-adherence to the non-pharmaceutical protocols of COVID, and this is contributing to AMR, to antimicrobial resistance. There's also a lot of huge dosing of antimicrobials at every small opportunity. You just see people taking even antimicrobials like metronidazole are popped down the throat for every semblance of diarrhea and so on. Every available antimicrobial has also been repurposed, rightfully or wrongfully, for COVID-19. So you see that with COVID-19, a lot of antimicrobials have just come up and they're being used. Now we need to, what is our role as healthcare professionals? We need to engage the patients, and we need to engage them not just in educating them, but engaging them in the co-creation of the global action plan on antimicrobial resistance. Now, what's the role of the community pharmacists? They need to be trained and retrained so that they'll be more sensitive to the best ways to go about this. And then patient engagement and co-creation. We need to have patients who are activated, professional patients. These days, you now have patient experts. And these patient experts need to be brought in and, empowered, and then they can go and empower other patients. And then the term patient IEC, which is information, education, and counseling, it needs to be replaced by patient engagement and patient co-creation. You hear a lot of health professionals talking about patient IEC. Please, that is a thing of the past. Today, like the Roach lady Marlene talked about, it is about patient engagement and co-creation. So the patient has a say. So patient-centered healthcare is not just about the disease, but the patient being at the center. And many practitioners do not even have an idea what patient engagement and patient co-creation is all about. So we need to educate healthcare practitioners generally. Now, many patients are also not aware of these new developments, and many of them feel stigmatized, so they are hiding. And part of the contribution to AMR is because the patient is hiding and disguising, does not want to come out and consult the practitioner properly, and so decides to self-medicate without any knowledge. And then patient organizations themselves also need to be trained. Now, within the IAPO, which is the parent organization of this conference we are organizing, the IAPO recently launched the P4PS, which is just patient for patient surveillance. That they want to educate patients and use expert patients to educate other patients. And this is a deliberate policy to help to reduce antimicrobial resistance. So IAPO and the pharmaceutical industry, they jointly established this action fund, which is meant to help to reduce antimicrobial resistance in partnership with government. And this AMR Action Fund was actually established. You will see that there are a lot of international pharmaceutical companies participating in this segment. They have taken very active part. They want to help to fight off superbugs, because when you have resistance, the bugs are becoming resistant, and so they become superbugs. So we need to fight the superbugs, and these collaborations are very important, and they are ongoing. For the WHO, thank God the director started off this speech today. The WHO, along with the European Investment Bank and the Wellcome Trust, started off this AMR Action Fund, and a lot of other pharmaceutical companies have joined in. So I'll quickly round up. I'm not a member of the WHO, and I know WHO has spoken, but WHO has this 5-point global action plan on AMR, which I think that the community pharmacists have a key role to ensure that this is implemented. So community pharmacists in Africa have to help to improve awareness and understanding of antimicrobial resistance. They need to strengthen knowledge through research and surveillance. So we need to start getting data from the community pharmacists. Then we need to reduce the incidence of infection through IPC and WASH, which has been clearly said by the director of WHO. WASH is the sanitation, hand washing and all that, and then effective infection prevention and control. So the healthcare professionals, the members of the public, everybody has to join hands to do this. We need to optimize the use of antimicrobial agents by strengthening the antimicrobial stewardship and eliminating irrational use. At this juncture, this also belongs to all of us to do, but we have a big pharma leading us, and they need to sponsor and help to train healthcare professionals all over Africa. And we need to develop an economic case for more investment in new medicine, because the older medicines over time get abused, and that's what happens all the time. So moving forward, I'm concluding now. We have the AMATA. That is what we are doing as the International Alliance of Patients Organization. We have the African Medicines Agency Treaty Alliance, which was floated by the IAPO, and we needed 15 African countries to sign up to the treaty, to ratify the treaty. And I believe we have arrived at that now. So the African Medicines Agency will be launched very soon. That will help a lot. Once it is launched, it will help a lot in controlling the use of medicines all over Africa, in regulating, and so antimicrobial resistance will at least be contained. Then the P4PS, which is the Patient Safety Observatory, which is a research organ set up by the IAPO, is also working on collecting data. And then we have the AMR Antimicrobial Resistance Action Fund, which I told you was set up by the WHO, the European Investment Bank, and Wellcome Trust. That is also in action. And then today we will be launching the Pan-African Patient Alliance in collaboration with the pharma industry. And this is going to help to make sure that the patient voice is properly aligned, and like the IAPO always says, nothing about us without us. So I will quickly conclude by saying that there is definitely no doubt that the African community pharmacist has a key role to play in eliminating antimicrobial resistance. And to do this, he or she needs to collaborate with the pharma industry through research and surveillance. So I'm throwing this challenge out to the African community pharmacists to build up research and surveillance structure and make sure that this works well in collaboration with the WHO and with the pharma industry partners. Now we need to engage, that the African community pharmacists need to engage patients and empower them as co-creators of healthcare. So in engaging patients, you give them power, you give them a voice, you know, instead of a vertical relationship between the patient and the practitioner. It has to be a concentric and collaborative relationship in which the patient is at the center. Now, the African community pharmacist, or African pharmacists generally, needs to be updated in the Global Health Sector Action Plan on antimicrobial resistance. And we have followed this through by working in collaboration with community-based organizations, with physicians and other health practitioners in activating patient organizations towards the antimicrobial resistance elimination goal. So thank you very much for listening. Thank you.
Pharmacist Mrs. Bisi Bride. Beautiful. Thank you for that wonderful presentation. I look at 2 or 3 things. I mean, you've spoken wonderfully well. Community pharmacists have a very crucial role to play in mitigating this challenge. The fear we have is that with the high burden of disease in Africa, poor ratio of healthcare workers to the population, poor regulations, and all those are big challenges that we must contend with. And one thing that came out strongly from your presentation is patient engagement and co-creation. Over time, patients have become more than just a passive customer. Patients increasingly expect to access real-time information, access their own health data, and play a bigger role in their healthcare. And thank you so much, Mrs. Bisi Bright, for driving this patient-centered healthcare, which is patient centricity, saying that the patient is an equal partner in his own healthcare. It's not just a passive customer. It's not just a helpless person, but a co-partner in the healthcare. Thank you so much, Mrs. Bisi Bright. A lot of questions more will still come to you in the course of this discussion, but thanks for that beautiful presentation. So we go on to the next presenter.
Just
yes?
remember, Dr. Michael Anderson is next, yeah? So I think you've skipped the order somehow. Dr. Michael Anderson is, sorry.
Okay, all right then. Okay, all right, sorry for that. So we have Dr. Michael Anderson for his presentation now. Thank you.
Great, thank you. So I'm really happy to hear that this morning the topic of national action plans has already been mentioned several times. And this is the focus of my presentation. And I'm happy to present some of the interim findings of our research project today. So it focused on trying to assess the national action plans in 2 countries in in Africa, Egypt and South Africa. And it looked at assessing the quality of governance in those national action plans. So before I continue, I just want to acknowledge that the project itself was facilitated with some financial support from MSD, and also just express my gratitude to IAPO, who helped coordinate some of the stakeholder interviews with patient advocacy groups throughout the process. So just taking a step back, and talking about why national action plans are important. So some of this has already been covered today, but the drivers of antimicrobial resistance are across multiple sectors and involve multiple aspects of our society. So from human, animal, and environmental health, but not just, it's not just coordinating across those sectors, but also within those sectors. So from the healthcare sector, involving hospitals and community and long-term care facilities, and from the animal health, it's not just thinking about livestock, but also companion animals. And environmental health is very broad. It's talking about how we dispose of waste and our wastewater facilities, and also how specifically healthcare facilities get rid of waste that may have resistant pathogens and how that gets disseminated, and also how farmers are disseminating, getting rid of manure, which may contain resistant pathogens in themselves. So what I'm trying to get across to you is that the governments that are tasked with developing national strategies to combat this issue have to deal with multiple stakeholders, each with their own inbuilt behaviours, cultures, institutions. And this is where a national action plan comes in, because it helps us coordinate all these actions and make sure that we have a solid document that we can all refer to. However, designing a national action plan, there's a danger that can become a bit of a tick box exercise. And since the WHO asked all countries to develop a national action plan by 2017, the focus has quickly shifted to how the biggest challenge is not just writing a national action plan, but implementing it and demonstrating sustained action. So this is what we've been looking at the London School of Economics and Political Science over the last 4 or 5 years. We've developed a governance framework to assess how well designed national action plans are to support implementation. So just talking about just some more background. So we looked at a number of countries, but the ones that are relevant to the presentation today are South Africa and Egypt. So in both Egypt and South Africa have huge challenges in the respect that they report quite high resistance levels for certain bacteria, and also their antibiotic use is particularly for some broad spectrum antibiotics is quite high. So looking at the two countries, they're two very different countries. So South Africa has been focusing on this issue for quite some time. Some would even argue that South Africa is one of the leaders in Africa focusing on antimicrobial resistance, and they developed a national strategy long before some of the pressure from international actors around the kind of 2015, 16, 17 period. And they've since updated their national strategy to make sure that it has more of a One Health focus. Whereas Egypt worked closely with the WHO to develop their national action plan they have now that covers the period 2018 to 2022. However, that's the first national action plan Egypt has developed. So talking more about the governance framework. So I have a 10-minute presentation, and I'm only going to discuss interim findings, but essentially this governance framework draws upon a lot of the, it draws upon a literature review and a lot of the international guidance on this, including the WHO Manual for Developing National Action Plans. It covers 3 broad governance areas and has 18 domains and 51 indicators that allow us to conduct a what we hope is a more objective assessment of the quality of governance in national action plans. And each of the domains cover a broad range of things. So from how you design the national action plan, strategic vision is some of the indicators in there are around targets. Participation is what level of participation across the One Health spectrum, but also crucially from patient organizations and civil society as well. And what coordination mechanisms exist? Are they formal or informal? Is there a multi-sectoral committee? And then accountability, are there agreements in place if responsible organizations don't deliver on outlined objectives or agreements? And transparency, is the National Action Plan, is it freely available? Are the progress reports freely available? Are the progress meetings held publicly? And sustainability is around funding. Is there earmarked, allocated funding to implement the activities contained in the National Action Plan? And a big issue in Africa as well is, whilst stewardship, a key aspect of stewardship is making sure that we also have equitable access to antimicrobials across different population groups, as well as the appropriate use of antibiotics only when needed at the right place and at the right time. So there's many other domains. I'm not going to go through each in detail, but just giving you a flavour of what the governance framework is and what some of the indicators are. So if there's only one thing that you're going to take away from this presentation today, and the thing that I really wanted to emphasise is when we talk about this governance framework and the indicators, throughout the process, we argue that there is a role for civil society and there is a role for patients and patient advocacy groups. And this has been used very effectively in different countries. So particularly in the US and the UK, just countries that have a bit better knowledge of how the policies have developed, patient groups have done a great job of putting a lot of pressure on government to ensure that there is sustained action on antimicrobial resistance, using things such as reaching out to politicians and policymakers, encouraging food labeling, encouraging the use of antibiotic-free meat, and then obviously encouraging awareness and education about the importance of antimicrobials with school children, the public generally, and when they consult with doctors. So this has a huge role to play. And these are just the domains that I think are relevant to civil society and patient groups, and it's almost all of them. So making sure that they participate in the process, they're involved in coordinating actions, they hold the government policymakers to account, they ensure that the actions are transparent, that sufficient funding is allocated, that they feed into, also they have a role to play in feeding into research, into evaluating the effectiveness of antimicrobial policies, and awareness of the issue of AMR. So I wonder, I'm very interested in trying to stimulate debate today around to what degree do people think that civil society has been allowed to play a role in developing these national strategies in Africa. So just talking about some of the results, the interim report we've written is very lengthy, but just to give you some ideas. So we identify some gaps, some strengths, and some weaknesses. So it's not about criticizing the pre-existing national action plans, because there's a lot of well-intentioned and positive efforts that are already in place. But just from Egypt, one of the things we picked up on is it was positive that there's a One Health spectrum involvement in the development of the National Action Plan, but the extent of public involvement in civil society was very unclear. And from a transparency perspective, whilst you could access it on the WHO website, many of the stakeholders we spoke to in Egypt weren't necessarily aware of the National Action Plan. There was, it wasn't necessarily widely or freely available. It had to be requested. And then from a stewardship perspective, so there was a lack of legislation regarding antimicrobial use in human and animal health. And from awareness, we didn't find evidence of a nationally coordinated, sustained public awareness campaign on AMR. And from South Africa, we found a similar finding that it wasn't clear to what degree there was public or civil society involvement in the development or coordination of the plan. And whilst there was regulation for antimicrobial use in human health, there was a discrepancy between the application of this regulation in the public and the private sector. And surveillance, there was a gap in animal and agricultural sectors. And there was still, similarly to Egypt, weak regulation of access to over-the-counter antimicrobials in the animal health sector. And again, awareness was another gap that we identified in South Africa. So there wasn't evidence of a nationally led awareness campaign. So we have some recommendations. So I'm only giving you a snapshot of the report here. But we think one of the things we're keen to emphasize is for better consultation with a range of the stakeholders involved in developing this National Action Plan to improve that there's more, to improve the level of engagement and buy-in into the process. So we argue consultation needs to be led around banning access to antimicrobials without a prescription in Egypt and human health, and similarly in animal health in Egypt and South Africa. And then, as I already mentioned, we identified the lack of a nationwide multimodal public awareness campaign as a gap in both of the countries. And then we argue that any national action plan needs to have short-term, mid-term and long-term goals. So the long-term goals for these countries need to be trying to introduce some type of legislation or strengthening pre-existing legislation around access to antimicrobials. But also this is a delicate issue and there are dangers in terms of restricting access to vulnerable populations. So this needs to be tied into the universal health agenda. And particularly in Egypt, there's a huge movement at the moment to try and improve universal access to healthcare. So these policies shouldn't be developed in isolation. They should be developed in tandem. So there needs to be efforts to improve access to primary care services at the same time to ensure equitable access to antimicrobials. So I want to loop back to the point I was making originally around, I'm very interested in people's thoughts when they think about their countries in Africa and their national action plans that were developed. How much effort was put into speaking to patients to understand their perspective and involving them in the ongoing process of implementation and monitoring and evaluation of their national action plans.
Oh, thank you, Dr. Michael. Thank you so much, and apologies for skipping you in the order of presentations. Yeah, thanks a lot for. Okay. No worries. Yeah, thanks a lot for that. So can we call Kawaldeep to maybe? I think you have something to say, Kawaldeep.
No, yes. So sorry, Dan. Please queue on the next speaker. Please do keep the 10-minute limits. Thank you.
Dr. Chrispin, Kambili, please to go on with your presentation.
Hello, everybody. Good morning. Good afternoon. My name is Chrispin Kambili, and I'm with the Johnson & Johnson Global Public Health team here in New Jersey. Today, I will be speaking about drug-resistant TB in the AMR agenda. You have heard very wonderful presentations addressing this concept of antimicrobial resistance. And I think probably the most quintessential representative of drug resistance is probably tuberculosis. And I'll focus my talk on tuberculosis and its contribution, its role in antimicrobial resistance agenda. This map shows you where tuberculosis is. Normally you see a map that's drawn based on the square kilometers or square miles of land that are represented. But here, a map of the world has been drawn to represent where TB is occurring. And as you can see, the African continent is well represented. So is India and countries like China. So, you know, TB is not evenly distributed around the world. It is much more prevalent in some parts of the world. TB has been with humanity for a long, long time. And in the 20th century alone, TB killed about 100 million people. That's the same number of people that died from all the wars fought in that century. That's a lot of people. And today, as we speak, at this time point, there are 14 million people around the world suffering from tuberculosis. Tuberculosis is treatable though. But although it's treatable, many more people still die than we would like. And resistance to the standard anti-tuberculosis drugs is really a big challenge in us reaching the goals that have been set by World Health Organization, for example. So drug resistance becomes a big contributor to the sad truth of the suffering and the deaths that are caused by tuberculosis. TB wasn't always treatable, actually. A long time ago, people got TB and many died. These are data coming out of the 1960s before there was widespread treatment for TB. So these are people not treated for TB in India, and about 50% of them died. So people that got TB in the 1960s without treatment would eventually die. Some people sort of recovered. People said they were cured, but we know today that they weren't really cured. Their TB had just gone in remission and ready to come back again when it found an opportunity. And some people just went around life with continued positive tests and maybe transmitting TB in their daily lives as they walked about and did their daily work. So, you know, we risk actually going back to the times where there was no treatment for TB if we're not careful and if we're not diligent about addressing antimicrobial resistance. We might let antimicrobial resistance become something of a scourge in the TB world. Many of us believe that TB resistance is a man-made phenomenon that then later picked up momentum and spread itself around the world unconstrained. That's why we have so much drug resistance in the world today. And many of you have heard, including in this forum, how the COVID-19 pandemic has really stifled progress in control of many diseases and conditions. And we think in TB, approximately 10 years of progress have been lost because of the COVID-19 pandemic. Treatment has been hard to get by, prevention measures have been sidelined, and diagnosis is not at the pace that we would like to make sure that we are able to achieve. So let's go back to understanding where we've been with treatment of TB. So the first drug invented to treat TB was streptomycin. It was discovered in 1943. The person who discovered it got a Nobel Prize in 1952. And, you know, I heard a saying, ghosts of the past. So what was interesting was that after streptomycin was introduced, it was noted that many patients initially responded very well after getting injections of streptomycin, those that had TB. But after a few months, many patients started feeling ill again and losing weight again. And it was soon discovered that some bacteria were in fact developing resistance to the antibiotic, to streptomycin. There was a large clinical trial. The whole concept today of a randomized controlled clinical trial was actually it innovated in the TB world with the advent of these medicines in the 1940s, 1950s. The British Medical Research Council is credited with this method of randomizing patients to either receive a treatment or not to receive a treatment. And that's how these drugs were proven. But then this concept of drug resistance came rolling back and showing us that perhaps we weren't doing something right. But we learned very quickly that one way to prevent development of resistance, at least in TB, was to combine antibiotics. And luckily enough, by 1950, 1951, there were a few other antibiotics for treatment of TB that one could use in combination in order to mitigate the risk of infection and the risk of resistance. And you can see here, for example, if you use streptomycin alone, the rate of resistance is very high. And another drug that was available at that time was called PAS, para-aminosalicylic acid. And when you use that alone, again, you get a lot of resistance. But when you combine the two drugs, you almost didn't get resistance at all. So this concept of combination therapy, which today is used in TB, is used in HIV, is used in hepatitis C, it is a concept that was developed based on these observations that these microbes are very sneaky, as it were. Yeah, they are always on the lookout for an out. And if we're not careful and if we're not smart about it, they will always win out. So, you know, that period led to a very impressive output of discovery for new TB drugs. You see, starting in 1943 with streptomycin, in the 50s and in the 60s, all these drugs were discovered and TB became treatable. We learned how to combine these drugs and to cure patients. Patients were now being cured of TB in a short period of time. And unfortunately, humanity became arrogant, became complacent. We thought we had conquered TB. In fact, in 1968, the United States convened a scientific meeting, a meeting of the minds, where they declared that we are about to eliminate TB from the United States. And they started a campaign to defund the TB programs and all the activities that were supporting TB control because they thought we were there. We had reached the promised land. Unfortunately, we were not. TB came rolling back in the 1980s and the 1990s with forms of drug resistance that hadn't been expected, including resistance to the key drugs, rifampicin and isoniazid, which were the drivers of the cures that I mentioned in TB. And for a period of over 50 years, there was hardly any innovations in the treatment of TB. There are no new drugs developed, and people relied on these old drugs. In 2006, there was a cluster of cases of untreatable TB in a place called Tugela Ferry in KwaZulu-Natal in South Africa. 52 out of the 53 patients in that description had died. Many of them died before even the doctor received the report from the laboratory that they had TB. The WHO convened a meeting following that report, and the concept of XDR TB was coined in 2006. And that spurred renewed interest in the development of TB drugs, which has led to the new extensive, perhaps not a good word, somewhat impressive pipeline that we see today. And that is depicted in the slide I'm now showing you. There are products in development. There's a TB drug pipeline, but unfortunately, in spite of that apparently impressive pipeline, there's very little progress. Many products are not being moved forward in the pipeline. There's very little investment. We know that these things could work if we moved them along the pipeline and brought them to patients. But the forces are just not there. And we worry in the field of TB that sometimes TB is sidelined in the antimicrobial resistance agenda. For some reason, there are people that think that TB should not be part of the conversation, but I fervently believe that TB should be, because everything we've learned about how to not do antibiotics comes from that. And if we do not incorporate that in our thinking in other areas of antimicrobial resistance, we will lose the battle. And the reason is because TB, in my opinion, affects mostly poor people. And generally, poor people are subtext or a footnote in a global agenda. And that is unacceptable. And we all have to advocate that diseases such as TB should be at the top of the agenda every day. So to me, this is encouraging. But at the same time, I'm worried that we're not doing enough. We need to increase funding for TB drug development so that those drugs can be pushed along the agenda. We continue stewardship efforts, we've heard this word before, to strengthen and safeguard the few drugs that we have so that we do not go back to the pre-1943 time when we have TB germs that are resistant to all drugs. So that when you get TB, it's as if you are entirely untreatable. This quote that I put at the bottom there is one of my favorite. Man's only competitors for dominion of the planet are the microbes. And the ultimate outcome is not foreordained. It's not guaranteed we're going to win the battle against microbes. And COVID-19 is beginning to show us that indeed they are as formidable as we think we are. We all have a role to play, as was pointed out. We all have contributed to the development of antimicrobial resistance, and we all must work to try to fight this scourge. So policymakers, civil society, industry, healthcare providers, caregivers, patients, society as a whole has a role to play. And in TB, we like to say, we are all connected by the air we breathe, and we have to all hold hands in this fight. Thank you very much for allowing me to join in today, and thank you for the organizers for giving me this opportunity to share my thoughts.
Thank you, Dr. Chrispin. By the air we breathe, and we all have a role to play towards containing this big pandemic. Thank you, Dr. Chrispin. We really appreciate your beautiful presentation. So we go on to the next presentation, Dr. Nicholas Adomakoh, please. 10 minutes as usual for your presentation. Thank you.
Great. Thank you very much for inviting me to speak today. Good morning, good afternoon, good evening from wherever you're joining across the globe. Really an honor to be part of this panel, and have really enjoyed the previous speakers who have all inputted, a lot into the presentation, in fact, that I will be doing in the next few minutes. I only have 3 slides, and my remit is really to frame the sort of challenges that sort of drive the call to action around AMR, what the industry's response has been, and then to focus just a little bit towards the end in the few minutes that I have on the engagement with patients. And the title here is, I was just picking up on the language around describing the AMR pandemic. And I know Kaldeep mentioned Ghost of the Future. In fact, I actually wrote them down. Silent pandemic was used, and that's one that is seen in the literature a lot. I've said next big thing, although that is me being fairly conservative. And I kind of liked Danjuma's analogy of sitting on a keg of gunpowder. I would probably add to that maybe the gunpowder has also been lit. And really the analogy there is, how long is the fuse? And I'll explain that going forwards. So I'm Nicholas Adomakoh. I'm the Global Anti-Infectives Lead at Sandoz, a physician in infectious diseases by training. And so my first slide really is here just to frame overall what the key challenges are in informing our call to action. And first and foremost, just to sort of, milk the gunpowder analogy, the AMR is inevitable. This is one of our key challenges to address. Dr. Kambili had mentioned how very strong parallels between the global AMR pandemic and what's happening with TB. Antibiotics generally are unique amongst drugs. They certainly underpin what we've been able to do in terms of modern medicine, in terms of advancing life expectancy, etc. But they are unique in that the more you use them, unfortunately, the more obsolete they become. And this left-hand side of the slide here indicates the timeline of discovery of new antibiotics. You may or may not be able to read them, but the key really is just to follow the red arrows that come afterwards, which indicate that very soon after an antibiotic is discovered and launched for use, microbes do develop resistance. And if we sort of skip over to challenge number 3, in the past, and again, apologies if it doesn't look, you can't see the detail, but really again, is to follow the red dots, which indicate again over time, our ability to address this emerging resistance with new drugs. As has been well documented in the press and in publications, that pipeline of new drugs is certainly dwindling. And in an analogy with Dr. Kambili's presentation before, yes, we've had the same complacency around antibiotics, and it may even have been the same US Surgeon General that had declared the war against microbes was over because we had this prolific armamentarium of antibiotics. But as you can see over time, this has significantly dwindled, and essentially we have not discovered a new class of antibiotic since the 1980s. And so the pipeline is in danger of collapse, and we're doing, obviously, from an industry and a global perspective, what we can to sustain it. The drivers really are around the sort of scientific and technical challenges. The lowest hanging fruit have been discovered, if you like. There are regulatory and obviously market challenges that exist around this. Nevertheless, this ability to mitigate the increasing prevalence of hard to treat infections is diminishing based on our available antibiotics. And then moving to the vicious cycle, which really informs the countermeasures that pharma and indeed the global action or call to action against AMR is founded on. And in the past, as I was saying, we've had these new antibiotics that we've been able to introduce into the market. They've been used, unfortunately, in a less than meticulous way, you would say, to put it lightly. And ultimately, based on my comments before, resistance emerges and we go through the cycle again. Now, the issue is the more you expose these microbes to antibiotics, the faster this emergence of resistance develops. And so exposure, not only from an actual use, obviously within human medicine, but we heard earlier around One Health and exposure in animal husbandry, agriculture, and environmental contamination. And again, this informs one of the pillars of our responses from a pharma perspective. So ultimately, when we look at this sort of traditional approach to antibiotics and introduction into clinical use and the dwindling pipeline, we are moving rapidly towards this scenario, which was well described by Dr. Fuller, our first speaker, around what exactly is in store. And this is based on the famous O'Neill report, an economist commissioned by the UK government and the Wellcome Trust. And the model suggests that by 2050, our current 700,000 patients that die from untreatable infections will rise to some 10 million deaths per year. And as you can see in the graph, the burden, which already is significantly borne by low middle-income countries, will be, again, as mentioned by our first speaker, will be significantly borne by Africa and Asia. And one of the conundrums in the midst of all of this is that whilst we're trying to contain and curtail the use of antibiotics, there is a growing need for antibiotics across emerging low and upper middle income countries that are really driving antibiotic consumption. And in fact, more people die from lack of antibiotics. That's some 5.7 million is the sort of the figure that's usually quoted versus the 700,000 that die from antimicrobial resistance. So we have to get this balance right between ensuring access, but doing it in a very stewardship type way. And there are many challenges that face us in that. So to slide number 2 of 3, what is then the commitment that we as Sandoz, and we're a division of Novartis, we're the generics manufacturer of antibiotics, one of the largest in the globe, with a huge global footprint, with local representation in many countries across all the continents of the globe, and affording us that opportunity to really have an impact. Our portfolio is very wide, and so we cover a lot of the WHO EML, its essential medicines list from an antibiotics point of view. And so we really see this as a license to operate in this space, is really to shoulder this responsibility. And so as part of the industry alliance, Novartis is signatory to the Declaration of Action against AMR and to the industry roadmap, which is basically described through the 4 pillars below. And in sort of walking out and delivering through the roadmap, we obviously strive to offer a broad and flexible portfolio that addresses the diverse and local needs, from thinking globally, but certainly at a local level, harnessing information around surveillance. What are the critical pathogens that are being addressed within that locale? Do we need very broad spectrum antibiotics as a general for empirical therapy, or is this a location where narrow spectrum antibiotics would do? So understanding that the localization of how antibiotics to be used really needs to be embedded in what we do. We, again, as has been mentioned by many of the previous speakers, we work across sectors to help the most vulnerable and neglected populations. And within this grouping, we would put significantly pediatric patients, where formulations and access, especially at last mile to formulations, is very challenging. And we do where we can some adaptive work within our portfolio to address those issues. And as I said before, it's really about getting this balance right between the need for antibiotics to treat treatable infections and the need to steward those antibiotics heavily in order to prevent the further emergence of resistance. So the 4 pillars really are around responsible manufacturing. So this is ensuring that we curb environmental contamination through our manufacturing practices. And the Industry Alliance Working Group has signed up to the Common Antibiotic Manufacturing Framework. So this provides standards. They've already published predicted no effect concentrations when it comes to effluent from manufacturing sites, and these will inform the targets within that framework. And when we look at what's happened in the 4 years since the alliance was put together, we have some 70% now of products made by those within the alliance through their supplier sites will be compliant with discharge targets within the next 4 to 7 years. And 82% of owned sites already meet the Common Antibiotic Manufacturing Framework requirements that I'd put before. And this is data coming out of reports from the AMR 2020 Progress Report. So the commitments against which we have signed up to are reported on a sort of 2-yearly basis. In terms of responsible use, and Bisi really presented very well some of the ways in which we need to support making available antibiotics to healthcare practitioners and embed very strong antimicrobial stewardship practices. And we likewise have been in discussions with the Commonwealth Association of Pharmacists, again with a view to empowering that group that is very present in local healthcare structures, especially in rural settings in Africa, for instance, to address this. Oga Pharmacist, I'll put it as you had said, Bisi, in your presentation. And so 76% of those within the alliance have formal appropriate use and stewardship plans. A lot of that will involve education, both internally to equip our local associates when they engage with healthcare practitioners or patient groups or other partners, to be embedding that stewardship message there. Access, and this is really where Sandoz is key. Our goal and mission is really to pioneer access for patients, and within the group there are 81 percent of those have within the industry alliance have reported on access strategies. 63 partner across multiple sectors in order to improve access for patients. Interestingly, 47 have indicated that they do experience supply chain disruptions, and in this area, we have to just comment on the investment within supply chains within Europe at our Kundl site, which is the last or the only vertically integrated antibiotic manufacturing and distribution site outside of Asia, and our investments in there in order to ensure that supply chains are resilient across the globe. And then I think Bisi has already mentioned some of the issues around innovation and how industry is supporting funding to stimulate innovation in this space. Certainly our alliance members are developing some 50% of the pipeline that has been described by the Pew Trust. And generally, members do engage across multi-stakeholder efforts to sort of engage with push and pull efforts to bring new antibiotics to the fore. So ultimately, Sandoz will continue to build on its legacy of active engagement within this framework with a view to delivering significant impact in the fight against AMR and demonstrate strategic leadership within the industry. And so just finally, really to go into the patient and caregiver commitment. And over the last 10 years, clearly this has grown significantly within the pharma environment. And generally, we recognize the increasing awareness and empowerment of patients and the need for patient centricity in order to develop drugs and to deploy them appropriately in a way that really has an impact. And this commitment is something that we are embedding, to ensure that the perspectives of patients and caregivers are systematically embedded into our decision making. And this involves these 4 pillars below, where we are encouraged and certainly considering the respect and understanding of patient communities and respecting their independence, in addition to seeking, their insights and perspectives across the entire lifecycle management chain of our products. Conducting responsible clinical trials, and one of my colleagues is discussing that in a parallel session. As I said, expanding access to our medicines and including social business and other types of approaches to ensuring access to quality and affordable medications. And then obviously recognizing the need for transparency and reporting, not only on our outcomes and commitments, but also ensuring transparency in both non-financial and financial engagements as well. So we are leveraging this capability within Novartis and leveraging existing platforms in order to engage more effectively. I think it was Bisi mentioned this water, sanitation, and hygiene programs. This is one where, I think possibly only up to 30% or so of those within the industry alliance are engaging with, and this is something we are building upon. And this is really with a view to ensuring water safety, providing in collaboration with water charities, clean and safe water for local communities, and building on top of that education and awareness around AMR and how to build in IPC, sanitation and hygiene, etc. And then we have programs that run across low middle income country settings, healthy family programs that essentially are geared towards both providing resources.
Dr. Nicholas, could you wrap up the session?
Wrapping up right now. From a sort of broad portfolio of communicable and non-communicable disease products, but also, again, engaging with the community, empowering through education, awareness, etc. So from the commitment to patient and caregiver side, we do work together so that we can improve outcomes for patients and anticipate that this will be effective in mitigating the impact of AMR. And I'll stop there. Thank you.
All right, thank you, Nicholas. I think because of time, Tracie, please, the floor is yours. Thank you, Dr. Nicholas.
Thank you. Good afternoon, good morning, wherever you may be. My name is Tracie Muraya. I'm a policy advisor at React Africa. And while the program might mention Dr. Mefen Pundu, that's our executive director, unfortunately, he was not able to be with us today. So I will quickly take you through AMR initiatives in Africa, the reality on ground. We've already heard from previous speakers, and a lot might be or seem as a repeat, but mine is really to emphasize on the challenges we face on ground from a civil society organization point of view, but also highlighting on the different successes, the different initiatives that are actually already ongoing and how we can tie them up to further enable our patients and patient groups and make sure that it's patient-centric approach. So first, I will look at the policy matters. You've already listened to the very first speaker, Dr. Walter Fuller, laying down the policy matters from a WHO perspective and the tripartite plus as by and large. So to complement those efforts as well, we, as member states in Africa, also look to the Africa Union. The Africa Union Commission, not that I work for the Africa Union, but just to lay the perspective as well, has since then developed a framework, the Africa CDC Framework, Africa CDC Framework for Antimicrobial Resistance, to act as a tool to guide continent-wide policy matters AMR. And this is based on 4 goals, mainly to improve surveillance of AMR organisms. Sorry, I don't know why it keeps doing that, I apologize. To improve surveillance of AMR organisms among humans and animals, to delay emergence and limit transmission of resistant microbes, and then to also mitigate harm among the patients themselves when and if they are infected with resistant organisms. So Africa CDC is the one mandated by the Africa Union Commission to actually drive this. And they do this through the Antimicrobial Resistance Surveillance Network, whose core members are comprised of African national public health institutions. Now, this is formed, they are not really employed by the Africa Union, but is comprised of public health experts from the human health, animal health, environmental health, as the previous speakers have well laid down the One Health approach and the One Health nature of AMR, dictating the need for a multi-sectoral engagement. So then there's the National Public Health Institute's representatives and collaborate with Africa CDC's regional collaborating centers, the regional tripartite plus has already been spoken by Walter. And not only that, but also just incorporate national ministries of health, ministries of animal and agriculture, environment, so on and so forth. Importantly also, they do bring about incorporation of the collaborating centers at the WHO for surveillance. So a 3-pronged approach is used here, where they advocate for policies and laws that are already there to sustain the AMR response in the continent, engage CSOs, as I've already said, but also more importantly, and what has also really been driven by the ongoing COVID pandemic, is to build the human resource capacity. So one huge milestone that took place last year was that our member states heads of the African states, that is, have since then adopted this as a common position for addressing AMR. And as with any progressive and impactful program or project, then Africa CDC went ahead to report on the milestones that have been achieved in 2020. As I've already mentioned, the Africa Union heads of states and governments endorsed this as a common position in Africa. And this was after the Africa Union Task Force on AMR was put in place, and also, of course, the Africa Union framework was established and put in place. This they do in partnership with the partners listed right there in the first segment. And this is to mainly create awareness and more so education and understanding about the silent public health pandemic that we do have. And it's ongoing even within the ongoing COVID pandemic, which is quite dynamic and disruptive. But this is more worrying because it's in the background. And just from the previous speakers, we've seen the irrational antibiotic use going on, meaning we already have a situation that is probably going out of hand as we speak and as we see it right now. I will not mention everything that you see in front of you, but just to show the different facets that AMR, addressing AMR rather, has to incorporate. So apart from the direct approach towards AMR, there's also the indirect issues such as what has just been mentioned: infection prevention control, surveillance, and just from a One Health perspective, these are things that have to be put in place and monitored and evaluated, even as we go ahead in tackling AMR as a continent. On your far right, you will see that the Africa CDC, we do work with Africa CDC as React Africa, where we've already trained, that was in 2020, if I'm not, no, sorry, before that, we trained civil society organizations, and have since then incorporated them in a community of practice where we still continue to engage them. There's cross-fertilization and just exchange of experiences, which further now creates a wider community to address AMR. So that's matters policy. However, reality on ground is something completely different. And it's no rocket science that ours is a continent that is grappling through a variety of challenges, right from supply chain through to stewardship, as has been mentioned before, and they continue to hinder and riddle understanding of the full extent of resistant microbes and their impact on our continent. Walter already mentioned that the number of national action plans that have been developed, unfortunately, only a few have been approved by our member states, and a handful are being implemented because One Health really does remain complex. And what brings about this complexity of implementation? So unfortunately, majority of the national action plans, as has been mentioned already, were developed sort of in a rush just to meet the deadline that had been offered, or rather stated in 2017 at the WHO in 2015. So many of these just relied on the Global Action Plan for Development and Design and did not really take into consideration the costing bit of it, of the implementation and activities and interventions that have to be carried out. Then this is then riddled with little or no political commitment. And at times, while we might state it as that there's no political commitment, our member states are also struggling with what to prioritize, because ours is a continent that also is riddled with recurrent infectious disease outbreaks, weak regulatory systems. Then you have HR capacity that either might not be skilled, or even if they are skilled, then just the, there's a shortage. So who to place where and who does what work. So this then just further complicates everything that should be addressed as urgent matters AMR. So what we see on ground as REACT Africa, when we go out there, these are the roads that we have to use. So then you start wondering, then the patient who really needs to access the medicine or the healthcare system, let's just say it's a lady in labor. How does she, for example, on a rainy, muddy day, go through that road or semblance of a road that you see right there? It's already been mentioned, ours is a paradox and conundrum of access versus excess in terms of availability of antibiotics, right? And that there is a common picture that we see in many African countries where our medicines really, you cannot talk about storage or, just observing the proper supply chain and storage protocols. This is one of our facilities that we do go there to supervise, and we are forced to improvise, right? The facilities are not well equipped, or they do not have the resources to, for example, renovate or add building blocks that are well air conditioned to handle storage. So they have to rely, for example, on containers. There is almost no running water. This brings a problem with infection prevention control. And then waste segregation is an issue.
Minute to round up, please. Thank you.
Yeah, sure. Rounding up, and then our patients are forced to sleep there, and that is what we call a lab. So as REACT Africa, then we come on board and offer solutions that are that also look at the capacity of the health facilities that we have on ground. And so we use both bottom up and top-down approach, where we not only assist member states in developing and implementing national action plans together with the tripartite and Africa CDC, but also form movement buildings, or rather different movements within the AMR sector. We also are heavy on informing technical information to globally coordinated efforts. And finally, also just innovate and incorporate different stakeholders, right from students in primary school, in high school, journalists as well, and different stakeholders, so that we may be able to get to the ground to inform, let's say, for example, the grandmother back at the community who would not understand antimicrobial resistance. And to inform this, we do have a toolbox that targets and is able to inform the different stakeholders according to their different capabilities and different understanding using their local language. So the patient role then comes in from, and only after we have strengthened the multi-sectoral collaborations amongst us. We have strengthened our health systems, we have strengthened our regulatory systems, and that is the only time that the patient will feel confident enough to actually come and seek health care services from our sectors and feel that they are actually taken into the core of addressing their health concerns. And in that way, then they're able to understand the need for them not to rush to the pharmacy first, but the need for them to spend that little, maybe $1 to actually seek medical advice and get proper sensitivity tests to address their infections. And that way, then we are able to address AMR from not only the Africa CDC Framework point of view, but the global coordinated point of view. With that, ladies and gentlemen, I thank you.
Thank you, Tracie. Thank you so much. Ladies and gentlemen, participants, we're so behind time, so we might not be able to entertain questions. We want to now tap from the last, but by no means the least, Dr. Greg Frank. Want to tap from his wealth of knowledge for the final presentation of this session. Dr. Greg, please, the floor is yours. Thank you.
Thank you very much. I think as sometimes the statement goes, everything has been said, but not everyone has said it. So I'm going to try to minimize what may be some duplicative statements here. But to go in the realm of Dr. Nicholas of how do we describe AMR for silent pandemic, one term I think the WHO and the Global Leaders Group mentioned is the silent tsunami, as the waters in its estuary continue to rise, and there seems to be no end, and tsunamis can creep up on you without a warning system, so it can become sort of surprisingly dangerous. And so I think AMR is really that ever-rising water that will never really end, and we need to prepare now to really address it. And I won't speak to the burden of AMR and why we care about AMRs. I think the other speakers have really eloquently discussed, why we're all here. And I think what I'd like to take here is really highlight, what MSD is doing to try to address this issue. And Dr. Nicholas, I think, has spoke to many of the similar activities, especially the AMR Industry Alliance. But for those that don't know, I'm with MSD, and MSD has been a company, that's been around for over 100 years with a strong legacy of developing antibiotics, both for human, but also for animal medicine. And we have been discovering, developing, and commercializing infectious disease products for many years, as I mentioned. But I think importantly, we're one of the few companies that are still engaged with both a human as well as an animal portfolio. And we recognize that we need to be looking at the responsible use of antimicrobials and vaccines and preventive health practices, not only for human medicine, but also with the animals. And really, I wanted to emphasize the point that we've heard others make, that all too often, I think we as we get into a very complex problem, such as AMR is, that we look to our silos where we have the expertise. And I think I always encourage us all to continue to think about how we address AMR globally through that One Health approach, and in appreciating that we have to work with key stakeholders, both on the human and the animal side, to really achieve this goal. And appreciating that, the solutions that we take in both sort of theaters of war, so to speak, may not be the same, but they interact with each other, and we need to always have those in mind. An example, I think MSD is an animal health company as well, and we have a huge portfolio of products that are really moving to address this. And I think one data point, soundbite, if you will, that always resonates with me is MSD makes 1 billion animal vaccines yearly to support and prevent infections. We bring expertise, capabilities for companion and food animals, and we really drive antimicrobial stewardship practices in the animal agricultural space to really support the appropriate use of antimicrobials and the improved use of things like vaccines that help prevent us from using antimicrobials in the first place. And again, we encourage, as we all work together, that we don't forget about that part, because I do think all too often we focus on the human element of AMR and don't focus as much on what needs to be done. And I think Dr. Anderson and other comments really highlighted the importance of including a One Health approach as we address this. But a few words, and again, I will try to save you some time, Dr. Adda. One example of what MSD is doing, I think, on the AMR and the human side is really this concept of the AMR Industry Alliance. And Dr. Nicholas has already spoken about what this is. But briefly, this is a coalition of large pharmaceutical companies like ourselves, biotech companies, generics, and diagnostics that all really are driven by that common purpose of what can industry across all these sectors do to address AMR. And we have these 4 focus areas that Dr. Nicholas highlighted, access, appropriate use, manufacturing, and research and science. And I felt probably the best way to describe this is just give an example of what is MSD trying to do as a founding member of the Alliance to try to advance those goals. And let's start with, I think, with access and appropriate use, which I see as a 2-pronged issue. And I think we have to be cognizant, and we've heard many of the speakers speak to this, that expanding responsible access to novel antibiotics in resource-constrained settings in low-income countries is very challenging. We don't want to make accessible a novel antimicrobial and then run through the same problem that we've encountered and solved for ourselves in the past, where we overuse that product, it becomes obsolete very quickly, and we've contributed to resistance without really creating a durable therapeutic to save patient lives. So when we think of access, we really need to think about how we can couple that with improving that infrastructure for antimicrobial stewardship programs. And if you can do both hand in hand, I do think we would have a significant impact in disease. Now, I appreciate that's easier said than done. And one of the activities that MSD has been doing is we have an AMS investigator-initiated studies program that really drives academic investigators to support studies of how they can improve AMS within their own respective studies. And we've underdone 50 of these studies since 2015, 20% of them in LSCs. And for example, we've collaborated with investigators in both Egypt and Kenya within hospital systems to improve their AMS efforts. And I think they've been very impactful and seen as a model for others to look to. We've also done some activities that are more digital based, where we've had educational programs rolled out in South Africa via podcasts to really, again, try to find a way to reach healthcare providers that we can appreciate are overworked, especially in the time of COVID that has already resource stretched hospital systems. Dr. Anderson, I touched on this, where there's really an urgent need to expand surveillance systems at LNSCs. And we've heard about some of the efforts, the GLASS network from the WHO. And I really can't stress enough that if we don't understand how resistant trends are working, we cannot implement effective stewardship programs to ensure that we are minimizing resistance, that we're using the right drug at the right time for the right patients. And I can say, again, lots more effort needs to be done here. But MSD, Pfizer example, also has a large surveillance program. We've had a surveillance program called the Study for Monitoring Antimicrobial Resistance Trends, or SMART. And this was launched in 2002. We have over 200 sites across the world. 67 of them are low and middle income countries. And really, in some cases, it is the only surveillance mechanism in some countries to understand the trends of resistance. So I think we need to continue to build on these efforts, and I think find how we can tie them all together so we have a unified surveillance system that we can all draw on. And I think really one of the points earlier, I think was highlighted, Dr. Bright mentioned, innovation is important to AMR, and Dr. Nicholas highlighted the challenges of AMR. I won't speak to it, but I can't state the absolute deterioration of the pipeline. And sometimes I think as we look to how we can ensure global access, how we can ensure stewardship, how we can improve surveillance, we must always be cognizant that we need collective action to actually make sure this pipeline is healthy. Because if we are not developing these drugs, that ever increasing pace of resistance will outstrip our ability to make new drugs. And we'll find ourselves, I think, right back to where we started. And so that collective action to create sustainable innovation, I think, is a key goal that MSD as well as the Alliance shared. And as Dr. Bright mentioned, MSD and a group of 20 other biopharmaceutical companies, again, both Novartis and Johnson.
Dr. Greg? You're muted.
Can you hear me?
Yeah, fine. So just have a minute to round up.
Yep. So the last statement I'll make is I just lost my audio is really, as someone who's worked in AMR for many years, I cannot overstate the importance of having an engaged patient voice. This is such a tough area where it's an acute disease. You either get better or unfortunately you may succumb to infection. And I think can't overstate how excited I am to have IAPO really take on this international voice of AMR and really bring together the disparate voices that all are impacted by AMR. Sometimes you don't appreciate how many aspects of modern medicine is impacted. So I really want to say I appreciate the opportunity to come here and perhaps state what MSD is doing, but I think hats off to this organization to organizing today's discussion and hopefully continue to take that mantle of leadership and integrate the patient voice into this, because I think without that, we will not succeed in really fully solving this issue. So thank you very much. And hopefully I saved a couple of minutes. I think I did not.
Thank you, Dr. Greg. Thank you to all panel members. And thank you so much for the great insightful presentation. Sadly, we are so behind time, and we've even taken a little bit into the break time. So I think to round this up, we'll know that the loose end about this is probably the poor antimicrobial stewardship, maybe a little bit of poor engagement of patients. So, but we've seen that everybody needs to be around the table to contain AMR. AMR is a bug we need to stop. A keg powder, the gunpowder that we need, that every stakeholder needs to put hands on deck to ensure that we stop antimicrobial resistance across the African region and across the global world. So thank you so much to all the great panelists. I want to say thank you for the opportunity to moderate this IAPO, and then Kawaldip, I hand over the session to you. Thank you.